This lecture is unlike any, and you'll probably think this is good, any other lecture than this I give, because this is a straight descriptive anatomy lecture, which I started giving because you will have tomorrow a lecture by a former student of mine, Dr. Eva Chalice, who's a gynecologic oncologist. And I found that in the past, if I didn't give this lecture, you people didn't know enough to understand what she was saying, and you would embarrass me when she would ask you questions. Now, this class is exceptional. Obviously, Dr. Sorrento, he said to me afterward, he said, boy, these folks know an awful lot because you were able to answer almost all of his questions, and that's marvelous. I don't care about you, but it makes me look good. So, some likelihood, if I give this lecture, that if she asks you any questions, you will star equally as highly. Now, all right, here we go. This is the room where I can try again with the, but this doesn't need low lighting, so we don't have to worry about that. You ask, what is the purpose of this picture in a lecture on female pelvic anatomy? Because most of you can recognize that this is not a female. It is the only slide that never had of this muscle called the pyramidalis muscle. Some of you saw it, some of you didn't. And I mention it because gynecologic surgeons, from time to time, ask what is the significance of this muscle. It has no functional significance whatsoever. As the muscle arises from the superior border of the body of the pubis and inserts into the linea alba. But if you have two of these muscles side by side, and not that many people do actually, you may read that upwards of 80% do, but I read equally that less than a third of the people have it. But if you are doing a surgeon and one of your patients is one of the fortunate people who has this muscle, its apex of the triangle right here at the top is a guide to the linea alba. And sometimes it can be hard in an obese person or someone who's had previous surgery to actually figure out where the linea alba is. And so even after it can be distorted after you get to the subcutaneous tissue. So that's why I show you the pyramidalis, because an obstetrical surgeon may ask you what is the significance, and your answer is the apex of the triangle formed by the muscle is a guide to the linea alba. That's not much of a significance, but that's all that there is. Here's a picture we saw before, a schematic median sagittal section with our two diaphragms, abdominal and pelvic, highly stylized, and the peritoneum, parietal peritoneum here, and a demarcation now between the abdominal portion of the abdominal pelvic cavity, which is above this line, above and in front of this line, and the pelvic portion, which is below and behind this line. This pelvic rim is formed by a line through the promontory of the sternum, the superior edge of the pubic symphysis, and the arcuate line of the ilium and the superior ends of the pubis. So that line, pelvic rim, demarcates the two portions of the abdominal pelvic cavity. We know that the space behind the parietal peritoneum is called the retroperitoneal space. The space between, in front of the parietal peritoneum is called the preperitoneal space. And now, and I thought I was being very original, because I wanted to give a name to the space below the parietal peritoneum, because the inferior boundary of the parietal peritoneum is not the same as the pelvic diaphragm. The parietal peritoneum stops short of the pelvic diaphragm and essentially really runs almost horizontally, its inferior boundary almost horizontally between the superior point on the pubic symphysis to the tip of the coccyx. So there's a considerable amount of space between the lower wall, if you wish, or inferior wall of the peritoneum and the pelvic diaphragm. So I wanted to give it a name, and I put in parentheses subperitoneal space. I thought I was the only one ever to do that, but I came across an obstetrician who wrote a book who uses that term too, and he must have copied it from me, but I don't know. So we have a retroperitoneal space, a preperitoneal space, and a subperitoneal space. All of these spaces are filled with fatty connective tissue. Not so much in the preperitoneal space, really. Quite a bit in the retroperitoneal space, and quite a bit in the pelvis. The fatty connective tissue of the retroperitoneal space of the pelvis, that's this here, that's the retroperitoneal space of the pelvis, plus the fatty connective tissue of the subperitoneal space of the pelvis gets a name, and it is called endopelvic fascia. Now, this endopelvic fascia fills the space except where there are internal organs which squeeze it out of the way. And there are lots of internal organs in the female. There, in both male and female, there's a rectum in the retroperitoneal space of the pelvis, and moving into the subperitoneal space just before it pierces the pelvic diaphragm is the anal canal. There's the uterus and vagina, and the pubis and bladder, and the beginning of the urethra. So these organs squeeze all of this endopelvic fascia into localized regions rather than allow it to just fill that space unimpeded. Here is the uterus. Remind you, well, it may not be a reminder if you haven't looked at it at all. The uterus has many named parts. All right? The actual uterus is the thick brown thing here, and its lower or inferior part is called the cervix. It's more or less columnar. And then its oval part, superior to the cervix, is called the body of the uterus. And the junction between the body of the uterus and the uterine cervix is called the isthmus of the uterus. The cervix is invaginated into the vagina, so that the wall of the vagina actually rises up and then comes back down again to meet the cervix, leaving a portion of the vaginal cavity which surrounds the lower end of the cervix. And that portion of the vaginal cavity that surrounds the lower end of the cervix is called the fornix of the vagina, and is divided into an anterior fornix, which is in front of the cervix, a posterior fornix behind it, and two lateral fornixes, which are lateral to the terminal part or inferior part of the cervix. Emerging from the body of the uterus and heading out to the side are the two fallopian tubes, or uterine tubes. They are given there are regions of these tubes given individual names. There's actually a fair amount of the uterine tube which is within the very thick muscular wall of the uterus, and that's called the interstitial part of the uterine tube. Then about half of its free length is a narrow region called the isthmus. Then beyond the lateral half of its free length, it expands as the ampulla, and very near the opening of the uterine cavity into the peritoneal cavity is the much greater expansion called the infundibulum, which has these finger-like processes, more finger-like processes all around the margins of the opening, this is called the abdominal ostium, or the abdominal opening of the uterine tube. This is called the uterine ostium, or the uterine opening of the uterine tube. Fimbriae are all around the abdominal ostium of the uterine tube, and those fimbriae sort of swell up, and they're not muscular, but they almost grab the ovary just prior to ovulation, so that the ovum, when it is released, just doesn't float about randomly in the peritoneal cavity, but is shepherded into the uterine tube or fallopian tube. So that's and then the roof, or not roof, but the rounded superior border of the uterus is called the fundus of the uterus, and the sites where the uterine tubes join the body are called the cornular horns of the uterus. So that's just lots of terms associated with the uterus. I trust many of you will know what this is. Many of you may have been to Florence to see this. This is The Birth of Venus by Botticelli. You know what's going to happen. Not only is it a gorgeous painting, but Venus rising out of the sea reminds me of the way I view the uterus and its position in the peritoneal space, or in the pelvis. This is not what happens in embryogenesis. You'll read about that. But this is how I view it, because it makes it easy to understand all the ligamentous attachments of the uterus. So I need two people up here. So I want you to view this as the inferior wall of the peritoneum. That thing which ran from top of the pubic symphysis towards the tip of the coccyx. the lower boundary of the peritoneal cavity. Higher in the uterus, these are the uterus, it's as if the uterus forms within that subperitoneal space and rises out like Venus in the tropic current. Venus emerging from the ocean. And when it does that, it develops, obviously, a peritoneal fold on the front surface of the uterus and overlapping the uterine tubes and a peritoneal fold on the surface of the uterus. These folds, this fold is double-layered peritoneum. There's an anterior leaflet, which you're looking at now, and the posterior leaflet, which you're looking at now. The peritoneum, which surrounds the uterus, that is called the broad ligament of the uterus. I'm going to take this off for the rest of this lecture. So, here it is. This is when the uterus rises up, conceptually, not in reality, when the uterus rises out of the subperitoneal space and brings this layer of peritoneum with it, you get what is called, and that's what we're looking at, the broad ligament of the uterus. And we are now looking at the anterior leaflet of the broad ligament of the uterus. Here in the free margins of the broad ligament are the uterine tubes, and here they end with their fimbriae, just like my arms did, and this was my head, the fundus of the uterus. When you look at the anterior leaflet of the broad ligament of the uterus, a ridge is raised in it by the old gubernaculum, which has become the round ligament of the uterus. You will see this very clearly in those cadavers that are female. A ridge is raised in the anterior leaflet of the broad ligament by the existence of the round ligament, which is heading out towards the deep inguinal ring. If you look at the posterior leaflet of the broad ligament, you don't see the round at all. The round raised and ridge in the anterior leaflet, there's no sign of it if you're looking at it from the posterior surface. But when you look at the posterior surface, you see, in fact, a ridge raised by the other remnant of the gubernaculum, which is the utero-ovarian ligament, and the ovary itself, which, the way I described it to you, the gubernaculum pulled the ovary into the pelvis, and now I'm saying to you, it pulled it in between the two leaflets of the broad ligament, and the posterior leaflet then folds over the ovary and folds over the utero-ovarian ligament, which I then track between the two leaflets of the broad ligament. The actual lining of the ovary, I can't remember the name. Anybody taking stone? What the outer layer of the ovary is called? Try to think. The outer cellular layer of the ovary is, in fact, sort of a modified peritoneum. It merges with the peritoneum. And this accounts for the fact that there is a kind of cancer called primary peritoneal cancer, which is indistinguishable from ovarian cancer. And women even women who've had their ovaries removed can still develop primary peritoneal cancer, which is indistinguishable from ovarian cancer. Not nearly as common as those women who have ovaries, but it can happen. So that's because the outer layer of the ovary is really just a sort of specialized peritoneum, part of the peritoneum. If we take a parasagittal section through the broad ligament, uterine tube, and ovary, it would look not like this, but schematically like this. All right. Here is posterior. Here's anterior. Here's the anterior leaflet of the broad ligament, coming down like that. Here's the posterior leaflet of the broad ligament. There's nothing but peritoneum. In the free edge, the uterine tube or the fallopian tube, the anterior leaflet is bulged out by the round ligament, and the posterior leaflet is bulged out by the existence of the ovary, and, of course, we know the utero-ovarian ligament, because this section is through the ovary. Here's then the floor of the peritoneal sac that bounds the subperitoneal space superiorly. The broad ligament is divided into the zone between where the ovary bulges out its posterior leaflet and the uterine tube, and that's called the mesosalpinx. That double layer of peritoneum between where the ovary bulges out the posterior leaflet and the uterine tube is called the mesosalpinx. The double layer of peritoneum between where the ovary bulges off the posterior leaflet and the floor of the peritoneal sac is called the mesometrium. This here, and I should have labeled it, is called the root of the broad ligament. That is where the two leaflets of the broad ligament then merge with the floor of the peritoneal sac, the root of the broad ligament. The double layer of the posterior leaflet produced by the bulging out of the ovary is a little shorter. Double-layered peritoneal structure which connects the ovary to the rest of the posterior leaflet is called the mesovarium, the mesentery of the ovary. So we have these three regions of the broad ligament separate names: mesosalpinx, mesometrium, and mesovarium, all related to where the ovary pushes out the posterior leaflet. Here in this posterior view, to show you what these look like in a better drawing in mind, this is the mesosalpinx. The double layer of the peritoneum, which is the broad ligament between where the ovary is and the tube. Here's all the mesometrium portion of the broad ligament inferior to the ovary, and here's a very narrow zone where the posterior leaflet is double, and that is the mesovarium. There are other things it gets named in this region. Let's see, any of the things I talked about here? Now, here I just showed the round ligament bulge after it has emerged from the broad ligament, passing over the iliac vessels and going towards the deep ring. Here is something called the infundibulopelvic ligament. It is not a ligament, it is just the fold of peritoneum over the ovarian artery veins and lymphatics, which as you know, the ovarian vessels start in the abdominal cavity and come down and cross the iliac vasculature and end up going to the ovary, and they also supply the infundibulum of the uterine tube. So this is called, this fold of peritoneum over these vessels is called the infundibulopelvic ligament. That we'll see easily. We will not see, because you don't see it in a cadaver, this thing called the uterosacral ligament. This is a genuine connective tissue ligament, which runs from the isthmus of the uterus, that is where the cervix joins the body, around, there's one on either side, running around the sides of the rectum and attached to the sacrum, called the uterosacral ligament. Considered a major support of the uterus, preventing the uterus from dropping down into your vagina, which would be called uterine prolapse. So we don't see that, and I don't know why we don't see it, but they're very clear in living room. And if you come to the video tomorrow, where I'll show you a laparoscopic procedure on a woman, you'll very clearly see the uterosacral ligaments. The portion of the peritoneal cavity posterior to the uterus is called the posterior cul-de-sac. In some books you will read recto-uterine pouch. Some books you will read the pouch of Douglas. Every single gynecologist that works at this university, because it means all the ones I ever talked to, call it the posterior cul-de-sac. And in fact, every gynecologist calls it the posterior cul-de-sac. That's what it's called. And this little bit of peritoneal cavity between the uterus and the urinary bladder is called the anterior cul-de-sac. I point out to you that the posterior cul-de-sac is actually makes a contact with this opening of the vagina, or this part of the cavity of the vagina, posterior to the cervix. That cavity of the vagina, posterior to the cervix, is the posterior fornix of the vagina. And therefore, the posterior cul-de-sac, peritoneum of the posterior cul-de-sac, meets or separated only by a thin layer of connective tissue from the posterior fornix of the vagina. It means that it is a means of accessing the peritoneal cavity in women that is much easier than any means of accessing the peritoneal cavity of men. By sticking a needle, sheathed at first, through the posterior fornix of the vagina, you can enter the posterior cul-de-sac. Why would you ever want to do that? That's what clinical science is for. Right? Why entering this with a needle and sampling the contents of the posterior cul-de-sac is called a colpocentesis. It is not done very much anymore because ultrasound and CT and MR now actually can tell you what's in the posterior cul-de-sac. At least they can give you an idea what the contents of it are. What are the contents you're worried about? You know, in a normal woman, the only contents of the posterior cul-de-sac are fluid. just like the only contents of any coelomic cavity in a normal person is fluid, and fluid alone. But if a woman has bleeding into the peritoneal cavity, if a woman has an ectopic pregnancy, if a woman has an infection of the peritoneal cavity, this posterior cul-de-sac is not only the lowest part of the peritoneal cavity when that woman is standing, but it's also the most posterior part when she's lying down. So things tend to settle in the posterior cul-de-sac. And before modern imaging techniques, it was an important thing to know that you could sample those contents so easily and diagnose a potential cancer. Can someone here too? Cancer that's shed into the peritoneal cavity. You can diagnose a disease by sampling the contents of the cul-de-sac. You'll read in clinical satellites why much rare occasion which is still done.
Dr. Stern,
yeah.
Where's the pelvic diaphragm? Where would that be?
The pelvic diaphragm is here. This is part of the pelvic diaphragm. Here's the perineal membrane right there. Now, we don't see in the median sagittal section the pelvic diaphragm here, but we do see it at the back. Remember that? I actually drew some. Look at, see that like that? My drawing is essentially just like that. Here's the puborectalis part of the pelvic diaphragm. Here's with the anal-coccygeal-raphe part of the pelvic diaphragm. And the pelvic diaphragm would come down to meet the perineal membrane. Since we're in the region of the anterior genital hiatus, we don't see it here. Now, the connective tissue, part of the endopelvic fascia between the anterior surface of the rectum and the posterior surface of the vagina is called the rectovaginal septum. The connective tissue, or that part of the endopelvic fascia trapped between the back of the bladder and the anterior wall of the vagina is called the vesicovaginal septum. There's one other, now we talk about uterosacral ligaments. There's also said to be, by most older obstetrician gynecologists, a connective tissue band running from the fascia. Here's, by the way, here's the pelvic diaphragm in this coronal section. All right. In this coronal section, again, we're looking at the anterior leaflet of the broad ligament. It's been folded over here, dropped it, and that has allowed the uterine tube to drop on this side so you can actually see the mesovarium. So here, we're only looking at anterior leaflet. Here, we're looking at anterior and then the mesovarium because he's drawn it with the uterine tube flopped over. In the root of the broad ligament, most older gynecologists refer to something as the cardinal or transverse cervical ligament. They claim that there's a fascial band which runs from the fascia of the obturator internus, here's obturator internus, towards the junction of the vagina and cervix. Now, the fact of the matter is that no anatomist who's ever looked at it, and it's not me, but no anatomist who's ever tried seriously to look for it has found anything like this. And they've done all sorts of histologic sections and plastinated sections and things like that. They can never find anything in the root of the broad ligament that actually represents a fibrous structure. So, you'll hear people refer to this cardinal ligament, you'll hear people refer to this transverse cervical ligament. The chances are that it really doesn't exist, the structure. What does exist in the root of the broad ligament are these things right here, which are the uterine vessels. The uterine vessels run from lateral to medial to meet the uterus at the junction of the cervix and vagina. And they are important structures running in the root of the broad ligament. And about a finger's breadth from the vagina at the junction of the cervix and vagina, passing below the uterine vessels or inferior to them, is the ureter. And this is another relationship terribly important to realize how close the ureter is to the vaginal wall here. And it's very important to know where it is in relationship to these uterine vessels because they are involved in surgeries of this region. And so one uses the mnemonic water under the bridge. Water, urine in the ureter, bridge being the uterine vessels. And that helps you remember that the ureter fat is inferior to the uterine vasculature as the vessels are traveling in the root of the broad ligament. This is obviously from an obstetrics book. These folks just love endopelvic fascia. They give a name to every little band of endopelvic fascia in the world. See, he's giving a name to the cardinal ligaments, even though I'm telling you that I don't think they exist. The bands of endopelvic fascia that you have to know the names of are uterosacral ligaments here. All right. We've talked about those already. I don't think I actually asked you to know the names of any of the others. And they also then use these bands, these endopelvic fascial bands, to demarcate various spaces. And these are much more important than the names of some of these bands themselves. In front of the root of the broad ligament, remember, I'm going to use root of the broad ligament as essentially synonymous with cardinal ligament. The space in front of the root of the broad ligament is called the paravesical space. And that is where the obturator nerve is found, and where the pelvic nodes are found, by and large. When you're working in this region, the paravesical space, the space in front, laterally, but in front of the root of the broad ligament. The space between the urinary bladder and the back of the pubic bone and pubic symphysis is called the retropubic space, or the space of Retzius. And the space behind the root of the broad ligament on either side of the rectum is called the pararectal space. So this is not pararectal, paravesical are sort of obvious, and rectopubic is obvious too, except they usually call it the space of Retzius. Some things about the uterus itself and its relationship, the relationship between the cervix and the body, and the relationship of the cervix to the vagina. In the most common shaped uterus, I want to get away from the word normal. In the most common shape of the uterus, you find that there's almost a 90-degree angle between the axis of the cervix and the axis of the vagina. Here's the axis of the vagina. Here's the axis of the cervix. That's almost 90 degrees, and that is the most common form of angulation. This angle, by the way, between the vagina and the cervix is called the version angle. And again, I use the mnemonic for that. Vagina begins with V and version begins with V. So that is the version angle. But you can see that in some people, this angle is less or greater than 90. In some people, it's 180. And in some people, it's even more than 180 degrees. These are called degrees of retroversion. If it is not 90, but is greater than that, then the uterus is said to be retroverted. And obviously, you get to a very serious degree of retroversion in this person whose uterus is an angle of cervix and vagina is actually greater than 180 degrees. These used to be considered abnormal. That's why this is labeled normal. These are considered abnormal uterine positions. People would say that women who have retroverted uteri could not conceive or had difficulty conceiving. That's now known to be a bunch of baloney. Right? So you can have any retroversion, and it doesn't seem to have any impact on you at all. Now, the angle, here's the normal angle between the cervix, here's the cervix, and the body of the uterus, and that is, I don't know, somewhat, an obtuse angle here, which is somewhat bent forward. The body of the uterus is bent a little bit and forward on the cervix. That is called flexion of the uterus. The angle between the body and the cervix is called the flexion angle. This is the normal. Here's a highly retroflexed uterus. There's a highly antiflexed uterus. I don't know what retrosection, so forget about it. So here's a much greater angle on the side, a much smaller angle than you would expect. Here's an angle which is actually opposite to what you would expect. Again, flexion angles of the uterus were thought to be related to infertility and things like pelvic pain, and they're probably not at all related to these things at all. But you'll hear the terms. Antiversion, retroversion, antiflexion, retroflexion. And so you just have to be aware of what you're talking about. The uterus is supplied by the ovarian arteries on each side, and also, more importantly, these structures, the female structure of the pelvis, are supplied by the ovarian arteries and by the uterine artery. The ovarian artery comes down, is the major supply to the ovary, but gives and the uterine artery is a branch of the internal iliac, runs in the root of the broad ligament, and is the major supply to the uterus in the upper part of the vagina, and sometimes it gives off a separate vaginal branch as well. These vessels, the ovarian, here's the ovarian coming in on one side. Here's the uterine coming in. Up here's the uterine coming in. The uterine comes in conjunction with the vagina and cervix. Here's the ureter passing underneath the uterine vessels. These have an extensive anastomosis with one another. An anastomosis along the fallopian tubes because the ovarian artery gives a branch to the infundibulum of the fallopian tube. An anastomosis along the uterovarian ligament because the uterine artery gives a branch along the path of the uterovarian ligament. And these, you'll read about in clinical sidelights, can be so extensive that in fact, if you don't have a uterine artery for one reason or ovarian artery, my mistake, if you don't have an ovarian artery for one reason or another, the uterine can, in most women, keep the ovary alive. And more interestingly, if you've had to tie off the uterine artery, many women, the ovarian artery can keep the uterus on that side. So you'll read about this in clinical sidelights. Very important and extensive anastomosis between ovarian and uterine vessel. This little branch of the uterine artery which travels out along the round ligament has a consequence only that when you're doing a hysterectomy, you have to tie off the round ligament or cut through the round ligament, which is itself no real consequence. There's a little vessel that runs with it or inside it called Sampson's artery. This is in clinical sidelights. If you do your rotations here at Steinberg, and you do your third-year clerkships, the chances are very, very good that when you're at the operating theater with one of the surgeons in OB or GYN, they will ask you, as they're cutting through the round ligament, what's the name of the artery that runs around it, runs along it? And you're supposed to say Sampson's artery. And if you don't say Sampson's artery, then it makes you look stupid, and even more importantly, we also make you look stupid. So if you say Sampson's artery, it'll be very impressive. All right, it's in clinical sidelights as well. Here, I don't know if I showed this before, or maybe not, but this is the I think I did, the subdiaphragmatic plexus of a pregnant woman. The fact that she's pregnant is irrelevant to this particular thing. There's a celiac ganglion. Many of you saw your celiac ganglion dissection. Here's the superior mesenteric ganglion. Here's the intermesenteric plexus getting down to the inferior mesenteric ganglion. Here's the superior hypogastric plexus coming all the way down here, splitting into the inferior hypogastric plexuses, and when that inferior hypogastric plexus is joined by the pelvic splenic nerve, shown here, coming from S234, that forms the pelvic plexus, which then is the supply of the uterus, of motor to whatever extent autonomic. I don't even know the extent to which, probably the vasculature of the uterus gets autonomic supply. I don't know that the uterine muscle itself gets any autonomic supply. Maybe you'll learn about that later on, but if it does, it's not very consequential. But the vasculature does clearly get autonomic supply. Probably more importantly is, as you know, pain from everything other than rapid distension passes backwards along sympathetics, that this is the pathway of pain from, obviously, labor and from any disease of the pelvic region that could produce pain. Now, if you again come to the video tomorrow, you'll see a description of and a treatment of a disease called endometriosis, where some of the lining of the uterine tube has, well, that's not fair. Where this is, yes, all right, how to describe this. It is believed, yes, some of the lining of the uterine tube, which is normally shed, just like the, well, I can put this correctly. The lining of the uterine tube is not a major component of menses, of the menstrual fluid. But the lining of the uterus itself is the endometrium. That's the lining of the uterus. And that's supposed to be shed monthly and expelled through the vagina. But it is thought that in some people, some shed uterine endometrial cells go backwards through the uterine or fallopian tubes in and out of the abdominal ostium into the peritoneal cavity, where hopefully they're supposed to die. But if they don't die, they can set up residence in the peritoneum and grow there. They have little uterine epithelial growths in the peritoneum, private peritoneum of your abdominal cavity. That's called endometriosis. When that happens. In some women, that is, and most women who have it, in a degree, this is a very painful condition. I don't know why it's painful, but it is. Maybe they explain it in tomorrow's video. And you'll see how that is treated surgically in a very, what's called a conservative surgical treatment. That's shown in tomorrow's video. But a less conservative treatment for the pain. Yes, Tom?
I have Thomas. I've heard it hypothesized that the reason for the pain is that the endometrial tissue actually will bleed.
It bleeds, yeah.
And the blood is irritated at the peritoneum.
All right. We have two people who both enlighten me that the pain is due to the bleeding of the tissue and the blood irritates the peritoneum. Is that a fair statement of what you two are reporting?
That stimulate during the menstrual cycle, they stimulate those tissues as well.
Yeah, but the pain is from blood.
From blood.
From blood.
I don't know.
All right. Well,
That is what I've heard.
I'm not denying it because I have no idea. I'll be glad to believe it. Anyway, the surgery tomorrow shows you what's called a conservative surgical approach to treating endometriosis if it is a painful condition. Obviously, you don't know about it if it's not painful because no one ever looks inside the abdomen of a woman who doesn't have pain to see if they've got it. But a more radical surgical approach is, in addition to what you'll see tomorrow, which is a laser ablation approach, is actually removing the superior hypogastric plexus right here. And there are papers which say that if you combine these two things, especially if the woman experiences a lot of midline pain as opposed to lateral pain, that is a much more effective and longer lasting procedure for eliminating the pain of endometriosis than is the laser ablation by itself. So it just gives you, just highlights the importance of anatomy to realize that all the sensation from this pelvic region is coming back to the superior hypogastric plexus. Here now is the perineum. Boy, we will never do a section that shows anything like this because we just cut our perineum in half. And when you cut it in half, everything gets real hard to see well. But this is essentially the contents of a superficial perineal pouch. In a woman, a much more nicely drawn ischiocavernosus muscle around the crus of the clitoris on each side, more nicely than I do. A nice bulbospongiosus muscle shown on this patient's right side, hiding from view the bulb of the vestibule and posterior to the bulb of the vestibule, greater vestibular gland, or Bartholin's gland, and then this muscle, I have no idea what it does, called the superficial perineal, transverse perineus muscle. There's a pelvic diaphragm on this, and the external anal sphincter. Now, these are the muscles, and this is not even important. I don't even know why I mentioned it. But these are because this was only discovered in 1983. It's amazing that some things in anatomy have been discovered in my lifetime. Maybe it's not your lifetime, but in my lifetime. These are the muscles superior to the perineal membrane. These are the muscles inferior to the perineal membrane because here's the perineal membrane there, which seems inferior. Notice how he calls it inferior fascia urogenital diaphragm. That's the old label. Here's the perineal membrane. And so we're looking at things inferior to it. Here are things superior to the perineal membrane. The only reason I mention it to you is we know that men have, superior to their perineal membrane, a sphincter-urethral muscle, which gives them voluntary control of urination, starting at the base of the bladder and traveling all the way down to the perineal membrane and circling the urethra. Women have a sphincter-urethra too, but it is much shorter and soon starts to expand and envelop both the urethra and the vagina. So this part here, this is the side view of it, is called the sphincter urethrovaginalis. So because this thing which surrounds both the urethra and the vagina, it's people think, and I can't say this has ever been proven, because this portion that surrounds both urethra and vagina is less effective at constricting the urethra all by itself. Women have a muscle, according to this author, which is not ever found in men, and it's called the compressor urethra. Another muscle which arises from the ischiopubicularis and loops up over, there it is, looping up over the anterior surface of the urethra and back down to the other. So it is thought that this is a compensatory mechanism to give women the same level of urinary continence control because their sphincter urethra is less effective, the lower part is less effective because it has to encircle the vagina. I just point that out. I guess really what I'm pointing this out is that these muscles are different in men than in women. And so you should just know that, sexes have differences if you haven't discovered that today. Here is the roof of the vagina. So this is just a whole bunch of separate, isolated facts about women's anatomy. Here's the roof of the vagina. Here is the urethra, which sits immediately anterior to the vagina. And here is the opening of these little glands, which are called periurethral glands, or in this case, they're called urethral glands. Some of these are really small glands, which open up into the side wall of the woman's urethra. The most distal one is a larger one called Skene's gland, which opens up through a duct into the right at the opening of the urethra itself, and that duct is called Skene's duct, and the opening is called the opening of Skene's duct. These periurethral glands are believed to secrete a chemical substance which actually inhibits bacterial growth, because the opening of the female urethra is so much closer to the surface than the male urethra, which has to travel all the way to the bulb and corpus spongiosum, and therefore it's harder for bacteria to travel that long distance from the tip of a man's penis all the way to his bladder than it is for bacteria to travel from the opening of the female urethra to her bladder, because it's a much shorter structure. It is believed that these glands secrete an antibacterial substance to minimize the chance of cystitis in women. But generally, cystitis in women is more common than it is in men anyway. Here is now the vulva. You'll see, you may or may not see, but here's the glands of the clitoris. All right, here's the little hood of the clitoris called the preface of the clitoris, and here is the little thing where the two labia minora come and split, and they send off one branch which becomes the preface, and the other branch which goes ventral to the clitoris, which is called the frenulum of the clitoris. Here are the openings of Skene's ducts on either side, or just below, really, and to the side of the opening of the urethra. And here are the openings of Bartholin's glands. Now, Bartholin's glands, I haven't discussed what they do, but in fact what they do is they secrete a lubricant, because the walls of the vagina themselves are not secretory. So the lubrication of the vagina for intercourse occurs through the secretions of the Bartholin glands. And they are described always, and it sounds flip, but this is in every female anatomy textbook and every obstetric time. The openings of Bartholin's glands are described as being at 5 and 7 o'clock relative to the vagina. Now, it's important because when you're doing an examination of women, you'd have to look at the openings of Skene's ducts, and you'd have to look at the openings of Bartholin's there, because these can all become infected, and pus can exude from them, and so you'd have to make certain that the openings look clean and infection-free. And then the labia minora meet down here posterior to the vagina, and what is called by clinicians the posterior fourchette of the labia. And should you ever, and again you'll read about episiotomies and clinical sidelights, but if one were to do an episiotomy, which is not done very often anymore, it would be through the back wall of the vagina through the posterior fourchette. Fourchette, you'll have to know the term. We could get the OB/GYN here. And I think we'll finish with lymphatics, because I know you like it the most of anything. We know about pelvic nodes, the ones along the external and internal aortic vessels along the obturator nerve. And we know about periaortic nodes, the ones alongside the aorta. The ovary being supplied primarily by the ovarian artery brings primarily to periaortic nodes. But since of that anastomosis between the uterine artery and the ovarian, some ovarian lymphatics drain to pelvic nodes. So the ovary drains both to periaortic and pelvic nodes. Very different from the testis, which does not have any significant lymphatics that drain into the pelvic region. The testis just drains up to the periaortic region, where the testicular artery arises from. The fundus of the uterus can drain to periaortic nodes as well as to pelvic nodes, but most of the rest of the uterus drains only to pelvic nodes. And finally, there are some lymph channels which travel alongside the round ligament, maybe alongside Sampson's artery, if you will. out to the superficial inguinal nodes. Lymphatic drainage of the uterus to superficial inguinal nodes is not considered significant unless all of these other channels are blocked with tumor. If you have tumor in your extensive tumor in your pelvic node, then in fact the uterus may only find a possible lymphatic drainage through these channels along the Ron ligament to the superficial inguinal nodes. So if a woman with suspicion of uterine cancer for one reason or another comes in and prevents a superficial inguinal node involvement, that is considered a dire sign because it means all of the other lymphatic egress channels have been blocked by tumor. And this was the only lymphatic egress for uterus. Yeah.
When you say pelvic, do you mean iliac nodes?
Pelvic nodes were defined in my lecture on lymphatics as the name given to the external iliac, internal iliac, and obturator nodes. The combined name for those three groups of nodes are called pelvic nodes. That is all I have to say about women's anatomy.